This is Dr. Meyer from the UIW Low Vision Residency from 2019 to 2020. And my lecture today is on the road again, driving with low vision. So first, I'm going to talk about the driving requirements, specifically in Texas, then talk about the tests that we should perform on driving patients, talk about the visual accommodations for driving, and then identifying low vision patients in your practice. First of all, we'll talk about the driving requirements. Driving requirements are not federally mandated. They are not federally mandated, meaning that they are determined on a state-by-state basis by state law. Although the International Council of Ophthalmology published a statement in the vision requirements for driving safety, and it recommended that the unrestricted driver have a visual acuity at minimum of 20/40 with a horizontal field of 120 degrees and a vertical field of 40 degrees, which happens to be about the range from the dashboard to the top of the car. Assistive technology is allowed in a state-by-state manner, and Texas does allow bioptics. So this is a map of all the states in red are states where bioptic driving is strictly not allowed. Now I know that there are some other states that may allow bioptic driving. However, the patient needs to meet the requirements for driving without the bioptic. So really making sure that you check in on a state-by-state basis is huge. Something worthy of mentioning is that as long as you're adhering to the limitations of the license, the patient is okay to drive anywhere in the United States. For example, if a Texan bioptic driver was driving to California, driving through both New Mexico and Arizona, they are safe and legal to be driving in those states as long as they are adhering to the requirements of their Texas license. The Texas requirements, there are two components to the requirements of driving. The first being visual acuity and the second being a visual field. And we'll start by talking about visual acuity and your binocular patient. If either eye is better than 20/40, then the person is unrestricted in their driving. At 20/50, there's a little bit of gray area in Texas literature, but as long as you have a doctor's signature saying that it's okay to be driving, you're still unrestricted. Now, if the better seeing eye is 20/60 or 20/70, this is when we start to have restrictions. So these patients can only drive a half hour after sunrise to a half hour before sunset on roads that cannot exceed 45 miles per hour. And lastly, talking about a monocular patient, if a monocular patient, of course, meets the visual fields, which will be talked about in the next slide, their acuity must be 20/25 or better. There is no restriction criteria for monocular patients. So either you're 20/25 and you're okay to drive ever, or you're not. So the Texas requirements for visual field are actually not requirements, they're only recommendations. They do recommend 140 degrees horizontally, and there is no vertical recommendations. But remember that the International Council for Ophthalmology recommended 120 degrees horizontally with 40 degrees of vertical field. As an optometrist in Texas, we do not have the duty to report. So if a patient comes into us and no longer meets the criteria to drive, we do not have to physically take that license away or report them to the DMV, police, or any other state association. That being said, as a medical professional, we do have the duty to inform the patient that they no longer meet the requirements to drive and have that tough conversation. To the right is the Texas Vision form that can be found on the DMV website. If the patient brings this to you, all you have to do is fill out the visual acuity, visual field, and the signature, and they can send it with the patient back to the DMV. Requirements as an optometrist, the only tests that we have to perform are visual acuity and field of vision. Now, the driver's approach to driving, when a driver is behind the wheel, there's 4 stages to their reactions. First, a visual stimulus is registered and then localized and recognized. The driver then decides an action and needs to physically exert that action. Identifying if a patient can execute these functions is key to making sure your patient is qualified to drive. So, as clinicians, we must assess our patient to ensure that they are capable of identifying stimulus, making a decision, and then physically performing that action. So, in a clinician's approach, we first must identify if they meet the visual requirements. Then assessing if the patient can handle the motor capabilities to handle driving, and then the cognitive and processing abilities to make haste decisions, navigate routes, and pay attention to obstacles. This is the optometric testing that was mentioned before. Of course, visual acuity and visual fields are the only required testing, but there's other tests that are more indicative of driving performance, and those are contrast sensitivity and visual processing skills, which we will discuss later. So to start with visual acuity, the problem with visual acuity is that it involves high contrast targets and are not accurate in real life scenarios. Has a poor correlation to motor vehicle accidents and the causes of actual accidents. The functional acuity of individuals measures much lower in office than in the real world. And what is functional acuity? Functional acuity is the acuity that is possible during normal daily tasks with non-ideal lighting conditions and not perfect contrast. And I think an important statistic here is that functional acuity of a normal 20/20 patient is decreased to 20/40 when they are driving at nighttime, going greater than 55 miles per hour with their high beams on. I think this is significantly important for those patients that you have that are on the cusp of meeting those restricted cutoffs. So making sure that you educate your patients, at nighttime, you are not going to see as well as you should be, and you need to be conscientious and cognizant of your vision while you're driving to make sure that you are keeping yourself and others safe. Moving on to the functional visual field assessment, we kind of do that in 3 different ways. We need to have a good binocular assessment of their functional visual field. Of course, a 24-2 or a 10-2 is not going to get us that full 140 degrees of horizontal testing that we need. To start with, I'll discuss the binocular Esterman. So there's 120 points there, and 12 fixation points above the fixation target, 22 below, and then the rest out horizontally. And this is going to test about 160 degrees horizontally. This is tested with both eyes together, which gives you a really good idea of how they work as a team and get a functional acuity for behind the wheel. Other tests, these 2 tests are going to test the eyes independently, so left eye and right eye independently, and then you'll have to summate those 2 to make sure that they do fit the 140 degrees of uninterrupted visual field. The first being the Goldman perimeter. In the kinetic form, the light will come in and the patient will click when they see it, and then you'll be able to summate those 2 to see if you have the 140 degrees, and then our good old arc perimeter, which is my personal favorite test. The following tests that we're going to discuss are not run in standard optometric practices, but should absolutely be something that's considered when it comes to driving safely, because no other profession deals with patients' visual function and the safety behind the wheel quite like optometrists. Contrast sensitivity and visual processing skills hold a truer correlation between good results and safer, more alert driving. The first being contrast sensitivity. Contrast sensitivity impairments are more predictive of patients having a difficult time driving, more than visual acuity or field loss. A study was conducted where they created a contrast impairment in one or both eyes on otherwise 20/20 subjects. Subjects consistently performed poorer on driving tasks than the individuals with a visual field defect or visual acuity loss. And patients with a moderate contrast impairment, so something in this area of 1.25 log units, were 8 times more likely to be involved in a motor vehicle accident. And those statistics were the same whether it was one eye or both eyes. So even your patients with a pretty dense cataract in one eye are going to struggle behind the wheel. Impaired visual processing speed is a strong predictor of driving performance. Testing visual processing speed will catch more than just visual impairments. This testing can predict systemic and neurological conditions, including stroke, Parkinson's, and dementia, and patients that you would question their ability to drive in the first place. The way that optometrists can test for visual processing skills is through the useful field of view. This is an automated perimeter type test that tests patients' abilities to be both peripherally aware as well as centrally aware, which is considered a higher order processing skill and critical for safe driving. There are several different tests in this useful field of perimetry and ultimately measure the potential driver's functional field of view. The first test is going to track the individual's ability to quickly detect and localize target. The second one will tell how well a patient can divide their visual attention into both central and peripheral vision awareness. And this is definitely a skill that you need for safe driving. And the third test is going to determine the individual's ability to determine relevant targets amongst visual clutter. These skills are visually and cognitively demanding, which is pertinent to driving. And it's going to be a better predictor of driving ability and safety more than visual acuity and fields. The current visual accommodations that we have are, of course, a bioptic, which is a telescope-mounted device where patients have to dip down into their lens and quickly spot a distance task. I think it's important to mention that bioptic telescopes are used less than 1% of the time while driving for more spotting distant targets rather than using it while they're actively driving for the most part. They're going to more so dip in and come out of that lens using the carrier lens for most of their driving. The GPS, although not specific for visually impaired individuals, it definitely takes the stress off of spotting those distance targets because you have that auditory feedback of where to turn and what streets are and how to make appropriate lane changes through an auditory feedback. In the future, we might be able to look into self-driving cars as it's going to change transportation in general, but also who is going to be able to use these cars. It might open up for to be more inclusive for individuals of all abilities, but it's just not a current option that can be discussed in length. So the telescope in a bioptic driver is going to be mounted over the better seeing eye so that the worse eye is still there for peripheral awareness. A bioptic driver's maximum visual acuity is going to be an acuity of about 160 or 2200, rounded up in Snell and acuity. And the reason that this is because the maximum telescope allowed on a bioptic in Texas is a 4x. And that is the strength that we need to get to that 2040, 2050 for those driving purposes. The greater the magnification in the telescope, the smaller the visual acuity, or the visual field, excuse me. And this is something that the patients need to be aware of. So while they're looking through that telescope, they still need to maintain a horizontal field of 140 degrees. So bioptic driving training is essential for these patients. While looking through this telescope, the bioptic lens, we're going to create a ring scotoma immediately surrounding that target that the telescope is focusing on. This is a part of the training that the bioptic driver is going to need. So let's talk about bioptic training. So first, we're going to need to have really solid handheld telescope skills from these patients. These patients are going to need to localize, focus, and be able to spot, track, and train efficiently and effectively in a real-world setting. Then we can put them in a bioptic. Once they're in a bioptic, we have to train them with real-life bioptic skills, and they have to be comfortable walking around with that. So the first thing that bioptic drivers are going to have to work through is this nearness illusion. So as they dip their head into the telescope, the image that they are looking at is going to appear closer and more magnified. So we get a stark reaction from individuals. They might want to slam on the brakes because they think they're going to hit something, but they are, several feet, yards, miles away from that object, and it's not of immediate concern. It's something that you have to work out before we can get you behind the wheel. Another thing is that because of the increased magnification, we're going to have that reduced visual field and that surrounding paracentral scotoma, as I had discussed in the last slide. And then while looking through the telescope, the movement of objects is going to be different. So once they have those real life bioptic skills and they're comfortable using the bioptic, then we're going to put them in the passenger side. The passenger side, they need to get passenger skills similar to a 16-year-old. So they need to be able to receive and remember directions, be able to detect and react to obstacles using that bioptic, and also how intersections work and be comfortable with that. Something of significant importance with this patient population is their ability to control or deal with glare and light reaction changes, especially because these are the patients that can be very sensitive to light changes. We need them to be able to maneuver through situations where they might have a ton of glare or bright sunlight in their eyes and be able to safely maneuver a car. Once they have those passenger skills, then they can sit for a normal driver's test, the written aspect, and then once they have that permit, then they can go ahead and get occupational therapists that specialize in driving rehabilitation and adaptive technology and do extensive training with them before they sit for their driver's test. So all of this has to go on before we can sit to that driver's test. It's a very extensive rehabilitation process. The perspectives of driving with bioptics, I wanted to kind of mention two studies. The first one looked at the safety study, was a safety study that looked at visual acuity and determined that the greatest risk factor for bioptic drivers driving accidents was previous driving experience, which is not much different than in real life. Younger drivers, drivers with less experience tend to be more dangerous with or without a bioptic. The second study was a self-assessment of the safety of bioptic drivers. And what they determined was bioptic drivers were not overconfident and maintained a safe driving skill. The study was set up so the bioptic driver was driving and someone was sitting in the back seat, and their performance was graded by the person in the back seat, and then a self-assessment was recorded at the end of the test drive. And what they found out was bioptic drivers were not overconfident, and they knew when driving conditions made them uncomfortable and they pulled over. So those conditions would be rapid lighting changes, rapid weather changes, and when they didn't have someone to help them navigate in a busy area, in a busy, unfamiliar area. There's going to be two types of low vision drivers in your practice. The first is going to be a new driver, someone who's never ever driven before, but might have a more stable condition. I like to think about these as more of your Stargardt's patients, something they have a stabilized visual acuity, but they've never driven anything before. Whereas you have your experienced drivers with age-related and likely progressive diseases that you have to probably monitor on a closer basis. I'd like to take a little time to discuss about driving and the aging population. Patients associate the loss of their license with a loss of independence, and they can be afraid to get support that they need in fear that their license will be taken away from them. These conversations are really hard to have with the patients, and I never want that patient to feel like I'm taking something away with them without offering them a different service. So while I'm having these conversations, I like to bring up programs like Uber, Lyft, and GoGo Grandparent. GoGo Grandparent is a landline way for older individuals to have access to Lyft, and also make sure that they know about the public transportation in their area as well as other options. Sometimes insurance providers will offer rides to and from their appointments. I alluded to this before, that driving is more than just vision, but also relies on the cognitive and the motor abilities of your patient. Older individuals may have other non-visual disorders that may be affecting their driving. So a team approach to determine if the patient is fit for driving is really, really important, especially patients with neurological issues and cerebral vascular events. Other patients that might be in your exam lane are patients who have just underwent a stroke or a transient ischemic attack. And while I was doing my research for this lecture, I found out that the Texas Medical Advisory Board requires that patients that have underwent stroke or TIAs have a comprehensive driving test before being allowed back on the road. However, in a survey of almost 300 stroke survivors, 30% of them resumed driving, while 48% of them received no advice about returning to drive, and 87% of them did not have a driving evaluation done. So my take-home point is that I hope that the driving concerns sparks an honest conversation about overall ability to perform driving tasks while assessing patients' visual function. As optometrists, we can use visual acuity, contrast sensitivity, visual fields, and visual processing skills and get a good idea of how this patient might be behind the wheel. This is a list of the Texas resources that can help provide the training as well as the devices for these individuals, state agencies, federal agencies, as long as nonprofits and private resources, of course. Here are my resources. Any questions?